This particular videotape is going to be on fixed and removable dentistry. Today's patient was in a situation where she was going to have to lose many teeth. Having had some of her perio done and the teeth removed, we came up with a treatment plan that we would use conventional crown and bridge on her anterior teeth, replace her posterior teeth with removable partials. And today we're also going to incorporate 2 implants as part of our design for our removable dentures. Let me tell you where we are right now. Our preliminary mouth preparations have included the removal of, and I'm going to refer to my notes, teeth numbers 1, 2, 3, 13, 14, 15, and 16. So all of the upper posterior teeth, 18 and 31. If you look at the panoramic x-ray and the full mouth series of films, you will notice that there's dramatic loss of hard and soft tissue, both horizontally and vertically, on all of these teeth. We will also be removing today teeth numbers 7 and 10, 5 and 12. We'll be preparing teeth numbers 6, 8, 9, and 11 for provisional crowns or for provisional bridges. And we'll be grafting the sockets of 7 and 10 so that we will preserve some of the hard structures, osseous architecture for ponics. Our treatment plan is to make 2 3-unit bridges that will get its retention and a certain amount of lateral stabilization from 2 implants in the site of 5 and 12. We'll use Nobel Biocare 4.3 implants diameter by 13 millimeters. On the lower, this is the situation she's in down there. We'll place a single crown on tooth number 20 and tooth number 28, and those will serve as precision attachments for a lower Kennedy Class 1 bilateral distal extension partial. We have mounted this case with a transfer base, and we will use this transfer base in our records. One of the things that I'd like for you to get from this video is called the Applegate technique, in which we will do a modified transfer base to make our final impressions for our removable partial. The laboratory has fabricated for us provisionals that we'll be able to insert today. We have a 6-unit temporary bridge, provisional bridge, that will serve as a healing guide for our grafted areas in the position of 7 and 10. We did not make it in 2 pieces, simply for stability. Also, they have fabricated a temporary partial with wrought wire gold clasps to replace our posterior teeth. And as you can see, the laboratory has prepared the teeth, and they've given me a guide as to where my ponics need to go and how deep they need to go into the sockets so that we can create excellent emergence profile from the tissue and support the hard and soft tissue with our ponics while Beverly heals. Our temporary partial fits to that existing provisional like that. And so when she leaves today, she'll have provisional bridge, temporary partial. We've also fabricated a clear stent that fits in Beverly's mouth to help us direct the position of our implants. With her provisional bridge in, our clear stent will serve as a guide for implant placement. Even though we have the existing sockets to help us determine implant position, because we're going to be using this as a rigid attachment for a removable partial, we want to locate our implants in a little different position than we would if we were using it for a crown, shall we say. So what I'd like to do is actually place my implant just a little bit to the distal and a little bit to the lingual, so that when we set denture teeth, my female component of my attachment will have much more room under the lingual cusp than it would if we pushed it out to the buccal. It'll also give us the ability to make a nice buccal corridor and turn the canine without having to worry about running into an implant. This is all the part of discovery. And when the laboratory technicians were fabricating the provisional, the feedback I got from Terry at Newcraft Dental Arts in Athens was that we would be really kind of tight on the distal of the canines in getting any kind of attachment in, whether it was an implant or whether it was a brie dent or some sort of rigid attachment off the distal of these canines. What a wonderful thing to know at the time I'm doing my surgery, because what I'm planning to do is take a little distal wedge of tissue off behind 6 and 11, which will give much more room for the technicians to work to bring our major connector in, our minor connector over the top of the implant. So with this discovery, we're able to head off problems down the road. I can't tell you the number of people who will tell me, oh gosh, we got to the end of the case and didn't have enough room for the attachment. Well, that's not the time to find out that you don't have enough room. The time to find out is during this phase, when you can do something about it. No way you can do anything about it if you haven't set some denture teeth. And so by setting the denture teeth, determining where they've got to go, we have the ability to place our implants and know that when we get to the end of this project, we'll have plenty of room to work. Our videographer for today is Bright Blue Sky Productions. Elliot Dunwoody, Stephanie, and Ernest are going to be with us. And we're going to move now into the operatory and get started with Beverly. We start our clinical procedure. We've gotten Beverly already numbed up really good. And our goal initially is going to be to prepare the teeth that will serve as abutments for our crown and bridge. So I'm going to start on the right side, and we'll prepare number 6 and number 8. We'll leave number 7, we'll leave number 10, and we'll leave 5 and 12 until I have the abutment teeth prepared, just to keep everything clean and the area free from any kind of blood or anything like that. So I'm going to start by preparing 6 and 8. With our crown and bridge, our goal is to build a case from the outside in. I want to determine the external parameters of the surfaces of the teeth in conjunction with the neutral zone. So I've got to get enough tooth structure out of the way so that the laboratory technicians have room to put metal, porcelain, opaque, any attachments that we need. So we want to make sure that we work with what I would call a pattern. I would like to be able to get 1 3/4 to 2 millimeters of reduction of incisal edge reduction. Kathy, if you'll put that perio probe up. One of the things I like to do is I like to use a perio probe and make some measurements. Go ahead and measure 2 millimeters to determine where we want to go to get our incisal reduction done. This is fairly simple to do, and if you use a Sharpie marker, it will stay on the tooth. One of the things that the lab technicians I work with will tell you that the thickness of a dime is 1.5 millimeters, and the thickness of a nickel is 2 millimeters. So what we hope to do this afternoon is nickel and dime dentistry. I want to get between 1.5 to 2 millimeters off. I'm going to use a diamond burr. This is a Brasseler 5856018. It's 1.8 millimeters at the tip. It's got a 6-degree taper, and it tapers to 2 millimeters at the shank. And so I can use this as a depth cutting guide. But if you'll notice, I've also got my little black lines to work with. In preparing teeth, I learned in dental school, instead of shaving it down, actually make a cut. So we'll make our depth cuts right to the line. On canine and the central. So with those depth cuts, all we have to do then is just connect the dots. In knowing your armamentarium and the diameters of the burrs, you can verify that you have the right amount of space. After I've done my incisal reduction, then I'll make a depth cut in the gingival 1/3 of the tooth. And Elliot, I don't know if you can see this, but the angle of that handpiece, I am completely to the depth of the burr, which is going to ensure that I have 1.8 millimeters at the gingival. But I also want to get that much reduction in the labial surface, so I'll just extend my depth cut using my burr as a guide out onto the labial. So now I've got two-plane reduction mapped out in the central. We'll do the same thing on the canine. I'll make a depth cut in the gingival 1/3, then I'll come out onto the incisal 1/3 and do the same thing. I'll connect those, and now I have two-plane reduction. Now, when I was in dental school, we were taught to prepare the gingival first and then come back and do the incisal. Over the years, I've learned that to provide as much room as I can for the laboratory, I'm going to do the incisal reduction first, using the tip of that burr as a guide or a depth guide. I'll also break my contact with that burr. This will ensure that I give the lab two-plane reduction in the incisal 1/3, and we won't end up with headlights or opaque showing in our final crown and bridge. I was taught to prepare teeth by a dentist at the Medical College of Georgia by the name of Arun Nayar. And he used to say that under every tooth is a perfect preparation. With this incisal reduction done, I can then do my gingival reduction. We can then jump over, now open back up a little bit, to the canine and do the same thing. Using the tip of my burr as a depth cutter, I would encourage you to try this because it will ensure that you get your two-plane reduction. Now all I've got to do is come out to the labial surface and the gingival. Now I can prepare it just like we would have in the old days conventionally. This is a super coarse diamond, so I can actually get under the enamel. And instead of sanding or grinding something off, I'm actually shelling it off. This burr is only going to impart a 6-degree taper. Instead of an 8-degree taper. We'll make sure that we've got a nice 1 3/4 to 2 millimeter shoulder going through the interproximal, so the technicians have plenty of room to give us some good color interproximally. We can jump back to our canine now. Do the same process. I'm not so worried about the adjacent teeth as I break my contacts, just because they're going to be removed. But it is nice to keep them there and have them there as a reference. With the labial surface reduced now, we'll be able to jump to the lingual surface and carry that margin all the way around at the gingival. This is a fairly quick process. But I would encourage you to maintain an axial wall on the lingual for resistance purposes as well as retention. Now, if you notice, I've not done any occlusal reduction. So I'm going to do as much with this burr at one time as I can. One of the things I try to do also is take the sharp angles off. The technicians you work with will tell you that it's really hard to capture those sharp angles, even with our new scanning technology. Now I'll switch out my burrs and I'll switch to a 3mm diameter football diamond. Ideally, we'd like to have 1.5 millimeters to 2 millimeters of lingual reduction. So if I use a 3mm diameter super coarse diamond, I'll use half the depth. And so I'll just sink it to the shank and get half the depth. Just moving the burr side to side. You can let that shank of the burr serve as your guide. There again, we got to find some room for probably some lingual ledges. Be able to build our major connector with our partial. We've gotten Beverly to close now, and what you'll be able to see, the amount of reduction that we have is uniform. The incisal reduction as well as the lingual. You'll also see we've got a uniform amount of thickness for our porcelain interproximally. We have plenty of room to work. You'll also notice that everything's clean. We haven't chewed the tissue up and we haven't really scarred things up. When we take these teeth out, we'll have nice clean areas to work in. Okay? What I'm going to do now is jump to the other side, do exactly the same thing we just did, and then we'll bring the tape back up then.
Okay. How many now?
Now that we have the abutment teeth prepared, this is just a roughed out preparation. We'll have the ability to go back and refine these preparations, but we're going to get a lot of soft tissue changes. I'm going to go ahead and remove tooth number 7 and number 10. The periodontist has deemed them hopeless. We have a 9mm probing depth on the mesial and about a 12 on the direct distal. What I want to be able to do, though, is preserve as much of the hard and soft tissue as I possibly can. So I'm going to take a little bit of time and try and preserve the buccal plate. We'll spend a lot of time elevating. Beverly and I have been through this with several teeth, haven't we? And she knows that if she feels anything, all she has to do is let me know and I'm going to stop. Knowing all the while that there's no way to get a tooth out without using a certain amount of force. Okay, we were able to preserve almost all of the bone there, which is excellent. We'll jump to the other side now, and it'll be pretty much same song, second verse. Once we've got these teeth out now, we've preserved as much of the hard and soft tissue as we can. I can quickly try my provisional bridge in and see how close we are in terms of prep and prep design, and I can make any changes that we're going to need to make. If you'll notice in the provisional, we've got a nice ponic form that will help to support the hard and soft tissue so that while she heals, we'll create a bed for a ponic. The lab has just used their knowledge, skill, and judgment to get this as close as they can for me, and they're really very, very close. We'll put this aside, and one of my goals now is to graft these two socket holes. What we're going to use is LifeNet bone, freeze-dried decalcified bone, and Kathy has mixed that bone and rehydrated it with just a little bit of anesthesia, and we mix some tetracycline powder in with the bone. To graft the sockets, we're going to use BioGlide, which is a barrier membrane, and we're going to use a technique that Dennis Tarnow has come up with called the keyhole approach. The socket is about 7 millimeters wide, and so what I'll do is I'll measure 7 millimeters out, make a little mark. Can you see me a little bit? It just so happens that this membrane is 14 millimeters wide. So I'm just going to cut it in half. And then I'm going to create a keyhole. Silhouette. If you remember the old basketball keys, that's what you're looking for. Some people will call it a golf ball and a tee. So there's my keyhole membrane. We've got the other side of that barrier for the other socket. We'll slide it right down and kind of decide if it's long enough or too long. I'm going to take just a little bit off. This is particularly helpful if you've lost a buccal plate of bone and you're having to graft to get back the buccal plate. Okay, now with that barrier in place, I'll then put my graft material. You'll notice Kathy's not using her suction so she doesn't suck up all of the graft material. And I'm not going to fill this socket hole completely because I want to give that ponic enough room to help us generate some nice soft tissue and for it to exert a little bit of force on the graft for us. Kathy, if you'll hand me the suction, then what I'll do is I'll take out enough of this graft material to provide that space. And kind of clean any other graft material around the preps. This is part of the reason that I prepared the teeth first, so that my little surgical site, my little graft site would be not have tooth dust and debris all down in it. I can then just fold that over like a little manhole cover and provide a barrier. I can then try my provisional in and see that I'm putting nice pressure on that. You use that little stuff. We'll then just put two little sutures down just to hold that membrane in place so it doesn't kink up on us as we work. And what I'll do is at the lingual line angles, I'm just going to go right through the barrier and the palatal tissue, so it just tacks it down. We'll snip that off of there. Put one more on the mesiolingual. We'll lightly tuck this back just to make sure we got it where we want it. Yeah. This is going to support all the hard tissue, and the provisional is going to support the soft tissue. Then we'll use our provisional just to poke it back down and make sure that we got it where we want it. Now we'll just do the same thing on the other side. We've gotten the other side grafted, and as you can see, we did the same thing, keyhole, and we've made it so that our ponic will support the hard and soft tissues. The next step, what we would like to do today, is go ahead and get these bicuspids out. We'll slip this number 5 out. There again, I'm trying to preserve as much hard and soft tissue as I can. Is this an open beak or a closed beak?
Open.
Okay. You okay?
Mm-hmm.
I'm just taking it really slowly. Thank you. Great. Very good. And root tip over there. All right, we're good, CB. We're good. So we've preserved a lot of the soft tissue. Let's turn this way for me now. And we'll do the same thing on this side. This tooth really doesn't have a lot of bone on the distal. I want to preserve as much as I possibly can. Same thing. We've got the teeth out. We elevated a little flap on this side because we went after a root tip. Now my goal is going to be to place some little immediate placement implants. One of the things I want to do is I want to go to the distal lingual with these just a little bit. We've already made our measurements and everything. We're going 3.5,
4.4.
but I'm going to start with a 3.5, 13. And I'm going to push this to the distal lingual as far as I can. We run it at 800 RPMs. Starting with a 3.5 diameter, and we'll jump up to a 4.3. I've made my pilot holes, and what I'd like to do is take my little surgical stent that fits in her mouth and make sure that my alignment is going to be exactly the way I want it, and we're dead on. This is just a clear duplicate of the temporary partial. We've got our osteotomy drilled. I'm going to make a couple of little measurements. I know that the crest of the bone where I'm working is right there. It's 3 millimeters from the soft tissue, so that I'm going to use a 13 millimeter drill. So I got to add 3 millimeters to it, so I'm really going to use a 16 millimeter drill. so I can just jump up one size in the surgical kit. We should be really close to this already. There we go. We can go ahead and place our implant on this side. Since we're in maxillary bone, I'm not going to use a screw tap. There's our 4.313. We're going to be running this at 35 Newton centimeters without water. As you can see, it shuts it off right at the 35, and I'll do the rest with a hand. Yes, Beverly, this is actually a socket wrench. We know that we've already got 35 Newton centimeters, but my torque wrench will verify that. I can then remove the torque wrench and verify that I'm right at the crust of the bone. Okay, let's go ahead and put a healing cap. I've got my tri-lobe implant head in there, and I put on the maxilla, I put my lobe to the palatal so I know I'm oriented all the time. I just finger tighten those, and I'm not going to put anything in there. We're going to let the clot fill in on the buckle. Okay, now we'll do the same thing on the other side. Alrighty then. What we've done now is we've gotten our implants placed. We had to elevate a flap to get the root tip out on this left side, which was really good because we saw a flap procedure on this side, and then we were doing a flapless on this side. We were able to get 35 Newton centimeters plus torque on both sides, and so I feel real good about the fact that those are going to heal in just right. Now all we've got to do is get our provisional relined. We'll try our little provisional partial to see if we fit good. Man, that's lovely. Bite together for me now, please, ma'am. Open just a little bit. Let's let your jaw just relax for a minute. And close. Good. We're sitting kind of on top of those implants, so I'm going to go relieve that. Kathy, I'm going to let you set up to open for me now. To reline those provisionals. Okay, open again for me now. What Kathy has done is she's put cavity varnish on the prepared teeth to protect them from the acrylic, and then we've coated those teeth with mineral oil, which will serve as a separator and a lubricating device so that we can get this thing off of there. If I didn't have a temporary partial to go in, I would be using a putty matrix to seat these crowns, but I'm going to use the temporary partial as a seating matrix. Now this provisional is acrylic on the inside, composite on the outside. These provisionals fit so well that the laboratory's just done a marvelous job of making them almost to my preps. There won't be a whole lot of acrylic necessary in these to fill in any gaps. So I'll just put a tiny bit in each one of the abutments. I have made a little vent hole in the lingual of these so that we'll let any excess out. And Kathy is actually lubricating the temporary partial with Vaseline so that we don't get the temporary partial and the provisional as one. Let's put just a little bit more. There you go. Thank you. Perfect. Perfect. This, frankly, is where the rubber meets the road. A little temporary parcel just fits great. And while I'm holding this in place, why don't we just use 2 cotton rolls and let her kind of hold it in place. Bite together for me now, and just squeeze a little bit. While we're holding that in place, all I've got to do to trim this temporary is take an Explorer, trim up a little bit of excess that's there, not much. Okay, now open for me. I'm going to slip that temporary partial out for a second. Thank you. A little temporary bridge came right with it. I can do the same thing now and trim the lingual of this just a little bit with my Explorer. I've slipped the temporary partial out, and there was a very, open for me now, a very thin film of acrylic. Now keep in mind that this provisional is kind of our first swing, and it's much more of just a surgical healing guide than anything else. Yet, we don't Beverly walking around town with ugly teeth. And frankly, these are beautiful. If you look at these, let your jaw relax and close on your back teeth. If you look at these in comparison to her natural teeth, we've already got a really good idea of where we're headed shade-wise. This is why I think it's critically important to have the laboratory technicians involved in a case really early. Get them involved early. Let them start to look at what sort of shape and what sort of colors that we can deal with. Terry's done a real good job, and particularly in the centrals and canines, of picking up the colors just in the plastic. Open for me now. You'll notice, too, that we got rid of Beverly's diastema. We talked to her about the fact that she had a little space between her teeth, and she reported to me that that space didn't really come up until she started having some periodontal problems. And so we elected to close it back. Now, if she doesn't like it closed, in our final product, we can open it back up. But for our provisionals, this is going to give us a lot of strength for these things to stay good and solid during her healing phase. Is look how the interdental papilla now are going to be sculpted by this ponic and this little projection that we make up into the tissue. That part of the ponic is going to be preserving the soft tissue, the attached gingiva, and the interdental papilla. Now I can add to this, or I can subtract from it to put pressure on either side. This is composite shell on the outside, so I can just add my composite that I have here in the office. The other side too. We learned from Walter Gephardt about zeniths, and so the zenith of my prep on a central is going to be right where my Explorer is. And so my prep needs to go up higher here so that this line angle can go right up under the tissue. The same thing here. The line angle of this number 9 needs to go right up under, and the zenith of my prep needs to be right there so that they will intersect up there. In terms of a lateral, the zenith is dead center, right in the middle, just like a canine. So we want that line angle to go right up under the tissue, support that soft tissue. I now have the luxury of being able to add to this anytime I want to generate the internal papilla just the way we like. This is why fixed and removable prosthetics to me is the hardest job in dentistry. You have to understand the concepts of fixed dentistry, but you also need to understand the concepts of removable dentistry and blend those to get your final result. Let's let your jaw relax again for me. Close on your back teeth. Yeah. Atta girl. Yeah, I'm going to need to adjust this side a good bit. Okay. We have gone to the lab and we've trimmed Beverly's provisional. It really didn't take that long because I was able to take most of it off with an Explorer. When I wanted to make sure that the margins were nice and polished. I also made a few adjustments into her temporary partial. Now let me tell you about the temporary partial. I've made it fit to the provisionals. And I've made it so that she can wear the partial when we get ready. I'm going to prefer that she not wear the temporary partial probably for about a week because I don't want to load up those implants that I've just put in. I just don't feel good about the acrylic kind of pounding against it. And if I can protect them for the first week, 10 days, 2 weeks, I'd feel real good about it. What I'll do then is when she comes back for a post-op check, I'll insert her temporary partial and I'll put a little soft reline, something like Hydrocast, in that so they'll have it to wear to church on Sunday. Okay? Now, we've put poor Beverly through the throes of hell here today, but I want you to take note now, Stephanie, if you'll come down, if you get down in the mouth with me. I want you to take note that really you can look at her tissues, her teeth. She really doesn't look abused. She's got a little bit of oozing, but she's already stopped bleeding. The implant sites are nice and clean, no debris. And part of the reason for that is we sequenced this whole appointment so that we did the preps first, extracted and grafted, then placed the implants. So we did the least invasive procedure first and worked towards the most invasive procedure. We'll try our temporary crowns back in. If you'll notice when we were making the provisionals, we put a little bit of cavity varnish on the prepared teeth. That kept the dent from being exposed to the monomer. And we cement all of our provisionals with Duraline.
Well, you know what? We can get it from here easy.
Really? You see what I'm showing you?
Oh, yeah.
What I've done now is I've turned Beverly upside down on her head. And well, the reason I did that is I want you to be able to see the lingual contours of the provisional. Right back where Kathy just brushed that suction, that contour back there is going to also provide for us support on the interdental papilla out on the labial. Plus, my temporary partial fits right to it. Fits right so that I'm not going to get any movement of the temporary partial or the teeth while she's healing. And that's critically important. We want to provide lateral stabilization, vertical support, and retention in this temporary partial. And our crown and bridge provisional is going to be doing that for us. We've cleaned the cement off. Right together on your back teeth now. We got our occlusion looking good, but Beverly is not going to wear her partial for about a week while she heals a little bit. Now, Stephanie, I'm going to raise her up. They do that at church on Sundays, don't they? Raise her up. I'm going to try and keep it so that you can now get a little bit of a better view of how Beverly's going to look. Can you even smile? Nah, your lips are completely dead. Okay. There she is. She's got just 2 little clasps that are going to show. And in the end, we won't have any clasps at all because we're going to be implant retained. The other thing you'll notice is the partial just kind of disappears into her mouth. The flanges are just in the right spot. But there again, I'm going to get her not to wear this for a couple of days because I want this area to heal where the implants were placed. If we slip out the temporary partial, now close on your back teeth again, you can see we got a pretty good color match and we're good and stable. All we can expect from this is really a good result. So we're good. I'm proud of you. You did great. It's a long morning.